confined joint space and the tightly stabilizing collateral ligament, as well as the close relationship with the surrounding, creates the advantage for developing the stiffness. An intra-articular infusion causes the joint to move into flex position, as this maximizes the elbow's capacity. Prolonged immobilization, we know that can lead to capsular contracture, and that early active mobilization after initial injury will be a factor of limiting residual problems. The main biological reason that the elbow is prone to contracture is the propensity of the capsule to undergo an inflammatory process, even in the event of minor trauma. And by transforming fibroblasts to microfibroblasts, it's created the extracellular matrix contraction and develops the stiffness. Now, the role of inflammatory genes and pro-inflammatory cytokines in the process of contractiogenesis has become an increasing interest in the literature, and I'm hoping that this will provide potential therapeutic targets. Now, how do we evaluate the stiff elbow? Obviously, a comprehensive history of what has happened, reviewing the physical examination, and obviously radiological evaluation, mainly CT scans, plus 3D, obviously, and in case we need an MRI, can be added. Despite the elbow stiffness, the elbow is relatively pain-free, and end-range tenderness can be found in most cases. Now, all this, in stiff elbows, the pathological changes of the posterior medial muscle can cause problems with the ulnar nerve, so we have to make a very good clinical examination of the ulnar nerve that is not involved in that case. Now, computed tomography with three-dimensional accurately localizes the loose bodies and impingements of osteophytes, assessing and planning arthroscopic. And then if you work in close relation with your colleagues in the radiology department, you can have these figures that you superimpose the opposite normal elbow onto the stiff elbow, and you can see that this is the movement that you can have out of the imaging department. Now, elbow stiffness, you all know that it's three categories: the extrinsic, which is mainly skin, muscle, or ectopic bone formation; the intrinsic, osteophytes, and mainly intra-articular incongruity and deformity. And obviously, most of the cases are combined, which means intrinsic and intrinsic as well. Now, non-surgical treatment can be discussed mainly in the extrinsic, which is soft tissue damage, and it can last not more than 3 months. After that, then somebody has to decide how to proceed. Operative treatment, there's no doubt that arthroscopic arthrolysis is the key element and factor to treating that problem, the elbow stiffness, improves joint visualization, reduce scarring, lower infection rate, but it needs expertise. So it's a tight joint with not enough space, and especially in the stiffness where it becomes the capacity of the elbow becomes even smaller. So it has lower complication revision rate, but according to Dennis Egendahl, it has a narrow indication. Relative contraindications are the inability to localize the ulnar nerve. Now, open arthrolysis, I think it's what most people do who are not experts in arthroscopy. It's a medial, lateral, or combined, or posterior, and we're going through them. For most of cases, the lateral approach is a highly versatile and widely used in practice, according to these recent review papers of Andy Watts and Denise Egendahl. Now, obviously, the column procedure, as we suggested, we discussed over the meeting, it has been the mainstream of treating the elbow stiffness, taking into consideration that before that paper, the only paper on elbow stiffness was the one by Jim Urbaniak suggesting the anterior approach. And you know that you lift off the ECRL and ECRB, and you can very easily get at the front of the joint. And if you lift the triceps, you can go back and deal all the problems at the back. Now, on the same paper, this is the medial column where you can go and identify the ulnar nerve and then lift off the flexor tendons and go into the into the anterior capsule. Now, this is a case of heterotopic ossification, as previously Tassos presented, and this is a huge heterotopic ossification, mainly filling all the space around the ulnar nerve. And you can see that this is what we excise, but you must be very careful because, as happened at that time, you end up with an unstable elbow, so you have to be prepared that if that's the case, then you have to reconstruct the medial collateral ligament. When pathology is both medial and lateral, you can use two incisions, medial and lateral, but an alternative is a posterior approach with two huge flaps that you can go at either sides. Anterior approach is mainly used very rarely in cases that you know from the CT scans that you cannot go easily from the either medial or lateral side, so you decide to go anteriorly. Now, the postoperative management means early active mobilization, as we've suggested, and patients should be motivated to regain muscle strength and reintegrate the elbow into daily life. Otherwise, the outcome won't be so successful. Now, we move into more complicated cases of elbow stiffness that the procedures are fairly more complex, and one of them is the interposition arthroplasty. I'm sure you all know the interposition arthroplasty is where you have a very aesthetic joint with no movement at all, and then you develop the distal humerus. You cover it up either with a dermis or, more recently, with an Achilles allograft. The Achilles allograft has the advantage that you can prepare the two slips and use it as reinforcement of the elbow joint, of the ligaments, the medial and lateral ligament. This is one of a case. This is an end up of a fairly difficult and internal fixation of fracture dislocation. And this is a 32-year-old heavy labor, 32 years old, and we did an allograft, a cadaveric allograft, a next fix. This is a pre-op, this is a post-op. And I think in these cases, this short group of patients, it's something that we have to look at. This is a fairly recent paper of both Morris from Mayo about interposition arthroplasty, that in the author's opinion, it remains a treatment of choice in some individuals. And obviously, if they go well for a year, they will continue to do for 10 years. And Mayo has suggested even if you redo the interposition arthroplasty, they can do well. And even they can do well if you do a total elbow joint. Then we have the OK procedure. We have the advantage of only one. I wasn't convinced at the time when Mayo produced that paper back in 2000. And you all know that you create a hole in the fossa, and then you can excise the whole osteophytes or whatever you feel it's more appropriate. It can be done arthroscopically. This is the only one case that I've done on the primary osteoarthritis. And this is a recent paper by In Ho. This is for primary osteoarthritis, and these are the results that he has recently published on the OK procedure. Last, total elbow arthroplasty. Is there a role for total elbow arthroplasty in cases? Well, should be reserved as a salvage procedure, and often other treatment options have been exhausted, and should be reserved for patients who are less than 60 years. So this is the algorithm that Denise Egedal suggested. You have a symptomatic stiff elbow. You have to decide if it's soft tissue or an osseous contracture. If it's soft tissue, then you carry on with the physiotherapy. If it doesn't improve with 3 months, then you move into operative treatment. Now, if you come to the operative treatment, you have to answer the following questions. Is the location of the ulnar nerve unknown? Is the ulnar nerve surgery required? Is the range of movement less than 90 degrees? If the pathology is extra-articular, if multiple previous incisions are there, and if there is a rotational impairment, then if you say yes, then you have to move into an operative lysis. Otherwise, you do it arthroscopic, and often I will suggest it lateral, medial, and bilateral, according to what you feel more appropriate. Thank you so much.